Okay, so my talk is entitled "Look at the Burden of Long COVID Under the Microscope," and I have no disclosures except for the meeting here today. And you know, we have spoken about this earlier in the meeting, so I'll go through just the more salient points that's relevant for the discussion of treatment. So we'll talk about mechanisms, and we'll linger on that a little bit more, and post-viral syndromes, because what we really want to do is get to treatment and preventatives. So the history of COVID, you know, we talked about this, but I do feel that we're entering an era where we're at a state of polarization in the world about infectious diseases. It's hard to explain what's happening in the United States, but there's a little bit of an attack on infectious diseases given the COVID polarization. And actually, we have to all work together. And it's not just on this, but on detecting new organisms. Because of climate change, we're seeing you know, movement of pathogens north. We're seeing new and a fungal pathogen that just got identified in India, mergemycosis. We have to work together with global surveillance. The WHO needs to be strengthened in that way. Coronaviruses have actually been around for a very long time. Coronaviruses are RNA viruses, and likely they have caused severe disease at least 4 times. And OC43 was probably the etiology of the Russian flu. That was the so-called Russian flu in 1889. But interestingly, you can actually see reports, because we did have the medical literature in the 1900s, and in the early 1900s, about 10 years after the pandemic, there were reports of people living with lingering symptoms. And usually the reports were very vague, but I'll talk more about the influenza pandemic. We haven't had as many reports of post-viral sequelae from SARS, which is an extremely fatal illness. Unfortunately, it had a very high fatality rate. Of 8,100 cases, there were 774 deaths. And we also know where that came from in terms of the animal progression and how it entered human populations. And then the Middle East syndrome, it also was relatively limited, only 2,500 cases. Everything was linked to Saudi Arabia, and there hasn't been studied here about post-acute sequelae. Again, this is a very high fatality rate. The fatality rate of SARS-CoV-2 in terms of the actual sheer numbers of cases versus fatalities was much lower than these two. And because of that, we have the opportunity to study more of the post-infectious complications. So SARS-CoV-2 did get a lot of international attention. Of course, it led to a lot of changes in people's lives across the entire world and the declaration of a pandemic. But instead of strengthening the World Health Organization, unfortunately, the World Health Organization, which has been trying to pass a pandemic treaty, has not had countries universally sign on to that pandemic treaty. And we don't have a fully ratified pandemic treaty, which makes it really difficult, because we were thinking of even the acute phase of COVID-19 was funded a large part by the UK. That some of the really well done randomized clinical trials of helping us figure out about remdesivir, anti-inflammatories, were done in the UK. But we actually need a global coalition, as the panel that we just spoke about here, and global resources to go forward, because by declaring the end of the pandemic, there was a mistaken assumption at times that meant the entire phenomenon is over, that COVID is over. And that's not at all what the WHO meant to imply by putting the pandemic by essentially calling the end of the pandemic phase. Endemic still means ongoing. It still means that we have new infections every day. We actually have, we're having an uptick of new infections in the US and many northern countries. So they in no way meant to say that was over, and that was never communicated in their press conferences. But as we've seen in this meeting today, we haven't seen the global consensus around long COVID. So the global consensus of long COVID would have been improved if we had had a greater understanding of post-viral syndromes. And post-infectious sequelae, and how much in the infectious disease world we actually see that. And we don't just see that these days. We've seen that for more than 100 years, possibly from the Russian flu, definitively from the 1918 flu. And the 1918 influenza pandemic also was extremely high mortality. There are rates, there are estimates of 50 to 100 million people dying from the 1918 influenza pandemic. And the case numbers were not even collected, but they were enormous. And because of that, there was quite a bit after 1918 of not only recovering from the economic aspects of a global pandemic, but recovering from post-infectious sequelae. There was absolutely no treatments. There was just description. And the description usually was in Latin, and it was encephalitis lethargica was the main description. But if you look at that description, it really had many of the same features that we described today of post-acute sequelae of long COVID. Not just fatigue, but autonomic dysfunction, which wasn't described well there. And chronic muscle aches, changes in occupation, joint aches, and sort of a chronic, almost inflammatory, what it felt like an inflammatory response. So the proposed mechanisms of long COVID is what we've been talking about for the last 2 days of this meeting. And each one could have a specific treatment. There could actually be a combination of treatments for each of these, depending on the patient's most prominent symptoms. But we haven't gotten there. You don't go to a long COVID clinic and get a slew of treatments for viral persistence, which we had an amazing talk by Raul and Dino yesterday about how that isn't new at all, even with RNA viruses. Systemic and tissue-specific inflammation, I can tell you in the HIV world, we don't have true anti-inflammatories. We have statins now, and that's the new thing that needs to be rolled out much more widely among people living with HIV. But we don't have we have studies, but we don't have anti-inflammatories that we use routinely. Autoimmune mechanisms, that's the relegation of one specific field, which is rheumatology, and certainly hasn't been applied widely to long COVID, and then microvascular dysfunction. So though this seems to be more common after severe disease, there was a lot of severe disease. And then I think that Chantal said it really well in the last session that we have a lot of data on hospitalized patients, but we don't have good data on people who've had non-hospitalized patients. This is not a comprehensive list, but these are well recognized as dyspnea, which actually is very common after post-severe influenza, fatigue, dysgeusia or anosmia, that was really well described in COVID, headache, lightheadedness, and then a slew of other symptoms here, including chronic urticaria, which ends up thinking that this is more of an autoimmune menstrual cycle abnormalities, and then really importantly, what we just heard about, post-exertional fatigue, a very, very specific type of fatigue that can really be quantified. And the vaccines have changed this. There was actually just a Scientific American kind of layman's article yesterday about the burden of long COVID and how it has decreased. But prior to the vaccination era, the burden did seem to be higher the more severe the disease. Not just hospitalized, but being in the ICU was associated with a higher rate per 1,000 patients, almost a third. Actually, a full third of patients who were in the ICU would come out with post-viral sequelae, and then a fifth of those who were hospitalized, and then less than a tenth of those who were non-hospitalized, but it was still a significant burden, again, even prior to vaccines. And this is an important finding in the UK that, yes, I do think that the duration of symptoms, at least by this UK study, does decrease over time, but you can see that it's decreased, but that still leaves a lot of people underneath that curve at the end who still have persistent symptoms. And it's that symptomatology that 3% having still symptoms by 12 weeks, which is full 3 months after the infection, that's a very high rate, still under the curve, though luckily a lot of people, at least early on, did recover. So I think vaccination, I don't think it's disputable. I mean, there's not a randomized trial of people of vaccines versus not vaccines and seeing the post-viral sequelae, but there's very, very nice observational analyses that really vaccination has decreased post-viral sequelae, and it doesn't seem to be necessarily associated with more and more boosters, but it definitively was associated with 1 versus 2 doses. 2 doses was better in terms of improvement in post-viral sequelae versus 1 dose. And of course, all of the vaccine candidates except for 1 all had an initial dose series of 2 doses. So these are the 5 vaccines that are approved in Europe. And of these 5 vaccines, all of them actually involve the spike protein, so of the virus. So going essentially, the spike protein, of course, is this little piece of virus that sticks out and sticks to the ACE2 receptor and sticks to the host cell. And all 5 of these involve either our mRNA technology, which are the top 2. There is DNA technology, usually inside an adenovirus, and the adenovirus is benign and does not replicate or cause cold-like symptoms. And then the bottom vaccine there is actually a protein linked to an adjuvant, so more traditional technology, because really mRNA vaccines aren't new. They were rolled out and thought about for MERS, but they weren't needed for MERS. So this was absolutely the first time they were widely applied. And so the vaccines really do induce excellent cellular-mediated immunity. All of the vaccines do. That's T cells, that's B cells. But what they don't do, and this is a really nice example in the 4th column over, is that measure that each of these companies, when they were developing these vaccines, did measure T cell responses to the vaccines, which meant that the early clinical trials had really low rates of really, really high protection, I would say, against hospitalizations and deaths, because severe disease and the protection from severe disease is really mediated by cellular immunity. But by definition, antibodies come down with time. Mucosal antibodies, systemic antibodies, that's just by definition. And that is why these vaccines really can't prevent all infections. They absolutely prevent severe disease. They hold up against variants. That was both with T cells and B cells, that the original vaccines even produced T cell an immune response that still holds up against variants from Alpha to Omicron. But what they can't do is continue to keep antibody levels up high, because that the body naturally will wane in terms of their antibodies to all infections or all vaccines that we've seen. As we've seen the emergence of the variants, Omicron was absolutely the most transmissible. Alpha was very transmissible. Delta was very transmissible. Beta and Gamma were not. And the Omicron variant was less severe. It caused less severe disease, but it also was extremely transmissible. So the burden of cases rose with Omicron and all of its subsequent subvariants. So being less virulent was not accompanied by fewer cases. And at this point, a large majority of the world's population, and I mean vast majority, probably over 90%, have been exposed to COVID, not just the vaccine contributing to immunity, but infection-induced immunity. And since there's so much transmission, there's variation that occurs, and now we're way, way past even the particular subvariant of Omicron that the new monovalent vaccines from the mRNA vaccines are directed against, but luckily they do seem to cover the current subvariants that are circulating. So this leads to the end of this, which is, this was the call. I mean, the Recover Initiative was the call for therapeutic trials for long COVID. And it was late, I mean, meaning this just got launched in March of 2023. And this is the call to action, but it's, essentially right near the tail end of where the pandemic phase was declared over. And we've really heard a lot about mechanisms in this meeting, but it is going to be antivirals. There is going to be an element of antiviral for the viral persistent cases, and those antivirals are, at this point, protease inhibitors. Those are the more powerful antivirals that have been developed. The nucleoside analog is very nascent, meaning it was not developed specifically for SARS-CoV-2, and we're getting new protease inhibitors for SARS-CoV-2. And then others will be anti-inflammatory agents. And these anti-inflammatory agents are listed here, but there'll be more, and they'll be repurposed, and they'll be new for it. And I hear the call that we have to move more quickly, and I think that's really what this panel is about with drug development. So thank you very much. I'm going to turn it over to Roger.